delivering unparalleled education, the Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion. In a world where knowledge is power, the Academy of Emergency Sciences celebrates a decade of excellence. For 10 remarkable years, we have been a beacon of unmatched medical training, founded with a steadfast commitment to delivering unparalleled education. The Academy of Emergency Sciences has consistently set the standard. Our distinguished faculty, comprised of specialist doctors, brings their extensive real-world experience to the forefront, ensuring that our students receive the highest caliber of education. From American Heart Association, AHA, Basic Life Support, BLS, to Advanced Cardiovascular Life Support, ACLS, and Pediatric Advanced Life Support, PALS, courses. Our mission is to empower our students to lead resuscitations with absolute confidence. Consistently top-rated courses, a testament to our unwavering commitment to providing an exceptional learning experience, proven by our countless satisfied students. Yet, our commitment extends beyond the fundamentals. Academy of Emergency Sciences goes the extra mile, offering supplementary courses, including the complimentary Advanced Airway course, enriching our students' knowledge. Join us in our mission to create a safer world through knowledge, expertise, and an unwavering dedication to life-saving. Academy of Emergency Sciences. Resuscitation is our calling, education our passion.
Good morning and welcome to the Resuscitation Essentials for Moonlighters, or R.E.M webinar. We want everyone to have the best learning experience possible, so please observe the following guidelines during the lecture. First, please keep your microphones on mute. Second, you are invited to type in your questions in the chat box at any time or ask them live at the end of the lecture. Lastly, the attendance link will only be posted in the chat box at the end of the webinar. A pleasant morning once again and enjoy today's lecture.
Good morning, ladies and gentlemen, esteemed colleagues, and young doctors. Greetings and welcome to our distinguished webinar series, R.E.M, Resuscitation Essentials for Moonlighters, a tribute to the decade of excellence at the Academy of Emergency Sciences. As an accredited American Heart Association training partner for BLS, ACLS, and PALS, we have consistently upheld the belief that resuscitation is not merely a task, it is our unwavering calling. Our motto, "Resuscitation is our calling, education our passion," underscores our enduring commitment to the art of life-saving. The choice of the acronym R.E.M for this webinar is not by chance. It reflects a profound connection with scientific research, suggesting that R.E.M sleep is when we most effectively consolidate learning and memory. Today, we gather to deepen your knowledge and enhance your resuscitation skills, with the firm belief that the wisdom imparted here will translate into lives saved. This year-long webinar series is generously offered free of charge, our humble contribution to advancing the realm of resuscitation education. We are resolute in our mission to empower young doctors and healthcare professionals with the essential knowledge required for their arduous moonlighting shifts. We express our profound gratitude for your presence here today, and we invite you to embark on this journey of enlightenment with us. Together, let us strive for excellence and remember, resuscitation is our calling, education our passion. It is with great anticipation that we look forward to collectively advancing our understanding and proficiency in resuscitation.
Good morning, everyone. This is Dessa, Admin Assistant at the Academy of Emergency Sciences. Today, I have the honor to introduce our speaker for this month's webinar. Our speaker graduated with a Bachelor of Science in Biology, cum laude, from the De La Salle University. She earned her Doctor of Medicine degree as a Dean's Lister from De La Salle University Health Science Institute. She completed her residency in emergency medicine at Makati Medical Center, ranking #1 in her field. She also ranked first as a fellow in the Philippine Board of Emergency Medicine. She currently serves as a consultant at Cardinal Santos Medical Center, De La Santos Hospital and Medical Center, Japanese Health Desk, and International SOS. In addition to her clinical roles, our speaker is also an instructor at the Academy of Emergency Sciences. With that, please join me in welcoming Dr. Kathleen Ann Medina Ange. Doc, the virtual floor is now yours. Thanks you.
Hi, good morning, everyone, and happy 10th anniversary to the Academy of Emergency Sciences. It's been a decade. I had no idea, but congratulations. So I'm glad that everyone is here. Let me share my screen. So hold on. It's a bit tricky. Let me share and then let me put this into Rare. So I'm sure everyone can see this. So today we'll just have a short discussion about the reversible causes of cardiac arrest, particularly the 5 T's of diagnosis and treatment. So there are 5 H's and then there are 5 T's, but we'll just concentrate on the 5 T's. For now, the 5 H's will be in another lecture. All right, so feel free to put in any questions in the chat box while I go through this lecture. So, according to the most recent guidelines, the American Heart Association guidelines for 2020, the main focus in adult cardiac arrest includes rapid recognition, the provision of CPR, defibrillation of any arrhythmias, so that's your chain of survival. But it also includes post-resuscitative care, and if you see in huge bold underline, the treatment of underlying causes. So the question is this, like the patient is already dead, like it's the cardiac arrest scene is very chaotic. You can only really treat the patient in a few minutes. Why do we need to diagnose reversible causes? Is there any real impact in ROSC or the return of spontaneous circulation if we are able to identify reversible causes? So let's take a look. So it is important to identify and treat all potential secondary reversible causes of cardiac arrest as soon as possible. Why? The rationale is certain conditions like tension pneumothorax and cardiac tamponade, which are part of the 5 T's, make CPR actually ineffective. And the thing is, they're often rapidly reversible if you do this early, within seconds to minutes. Now, if you delay in performing these treating procedures, they can worsen outcomes, and there's little chance either intervention will make the situation worse because your patient is dead anyway. Okay, so if you have a high suspicion that your patient has one of the 5 T's, we highly recommend that you try out one of the managements. Okay, so some real life statistics. So in a recent study in 2022 in one hospital, I think in Europe, so DeWolf made a study called Timing and Identification of the Cause and Treatment of a Cardiac Arrest, a Potential Survival Benefit, because there's studies about this. It shows for these resuscitation teams for in-hospital and out-of-hospital, they are manned by an emergency medicine doctor, so it's a specialist, plus his resus team. So during advanced cardiac life support, etiologic evaluations was performed in only 75% of resuscitation. So these are professionals, but they don't get to diagnose or think about the diagnosis of the 5 H's and 5 T's all the time. A presumptive etiology was found in only half of both out-of-hospital and in-hospital cardiac arrests. So it's difficult to find an actual diagnosis in cardiac arrest, but then when you do, it's very helpful. In 20% of the evaluations during cardiac arrest, unfortunately, our resus teams did not use the HS&T system. The HS&T system is actually also encouraged by the American Heart Association. So if you look at the algorithm, and if you also look at the AES algorithm for ACLS, you would see during your evaluation during a cardiac arrest, you always see evaluate 5 H's and 5 T's. So a significant association was found between the discovery of etiology and return of spontaneous circulation. So this is not the first study that has done this. Previous study did say that there's a survival benefit as soon as you find the reversible cause and return of spontaneous circulation. So the problem is also in this study, ideally, according to the AHA, the cause of the arrest, you should start looking for the cause of a reversible cause of an arrest, or 5 H's or 5 T's, should be started after the second rhythm check for non-shockable rhythms, or the third rhythm check in shockable rhythms, if you look at the AHA guidelines. However, so this will take around 250 seconds. You should start looking for a cause. However, in real lifetime, in a professional setting, it takes up twice the recommended time in practice, or almost 500 seconds. So it does have an impact if in return of spontaneous circulation. So it'll be prudent that you know, at the back of your head while you're doing your cardiac arrest, your cycles, to find your H's and T's. But yeah, no big pressure. I mean, the cardiac arrest, handling cardiac arrest is stressful enough, you know, which is why we're here to talk about it. All right. So what are the causes of reversible cardiac arrest? So if you look at the algorithm, they talk about the 5 H's, which is hypovolemia, hypoxia, hydrogen ion, which is acidosis, hypo and hyperkalemia, and hypothermia. The 5 T's, which I will be talking about specifically, is tension pneumothorax, their tamponade, cardiac tamponade, toxins, thrombosis, pulmonary or pulmonary embolism, thrombosis, coronary, which is almost all sudden cardiac arrests are suspected to have, okay, a heart attack. All right, so let's talk to the discussion of the 5 T's. We all know during a cardiac arrest, when you're running a cardiac arrest, it's very difficult to even do anything diagnostic wise. Okay, so there are clues to your diagnosis. If you are able or your team is able to speak to the bystanders or the relatives of what happened to the patient, you can find associated clinical conditions that can point to your 5 T's. So let's look at them one by one. For example, tension pneumothorax, if your patient just had mechanical ventilation, a pulmonary disease like asthma, COPD, thoracentesis, thoracic trauma. You might have tension pneumothorax if it also has suspicious signs. We'll talk about that later. Cardiac tamponade, if your patient has had history of post-cardiac surgery right away. Malignancy cancers, because cancer, especially in the chest cavity, can cause pericardial effusion. MI also, pericarditis, chest trauma again. You can consider cardiac tamponade, but you also need to look at the signs. Toxins. You can consider poisoning or overdose, either accidental or intentional, if the patient has had history of alcohol or drug abuse, altered mental status, classic toxidromes, for example, in opioid poisoning, you'd have pinpoint pupils and respiratory arrest and hypotension. So that could give you a clue. Occupational exposures, like a painter or in an industrial setting, or psychiatric disease, because even, for example, the patient has not overdosed on antipsychotic or TCA drugs, they also have serious adverse effects on the heart. So you can suspect patients with pulmonary embolism if they had recent history of being immobile, they've been bedridden for a very long time, recent surgical procedures, especially long bone surgeries, their peripartum. You can consider the risk factors of thromboembolic disease, which we'll talk about that in a few minutes. Recent trauma, again, trauma is a common factor to cardiac arrest. Presentation consistent with acute pulmonary embolism. We'll talk about that in a few minutes. And of course, the associated clinical conditions for coronary thrombosis is very simple. Sudden cardiac arrest, more than 96%. So that should be simple. Okay, but we'll talk about this one by one. So next, we'll talk about number one, tension pneumothorax. So what is tension pneumothorax? So if you see in this little image here at the right lower corner, so when the pleura or the lung is damaged, outside air will rush in to the pleural space, and you could see the outside air compressing the lung. And if you leave it alone, it's not treated right away, it's going to cause what you call a tension pneumothorax, where the pressure or the increased amount of air will crush the lung and also the heart, which is a life-threatening situation, or the patient have gone into cardiac arrest because of that situation. So what are the clues? What are your symptoms and signs? It's actually not very specific, but your patient usually has sudden dyspnea, hypoxia, hypotension. These are late signs, tachycardia, reduced breath sounds, usually on one side when you try to auscultate if the patient is still alive and breathing. If you have time to do percussion on one side, there is hyperresonance. That's a huge clue. Very rarely there are bilateral pneumothoraxes, but also keep in mind the history. So if he has asthma or he's tall and gangly, he smokes, COPD, past TB, chest trauma, you can consider tension pneumothorax. Now the classic signs of tracheal deviation away from the affected side, that's a late sign. But if your patient already presents to you in cardiac arrest, you can see this sign, and also distended neck veins. So these are the signs and symptoms you can consider if the patient might have tension pneumothorax. Okay. Now, the management of unstable pneumothorax, usually when they're like about to go into cardiac arrest or very unstable, already in cardiac arrest, is immediate decompression. So we call this needle decompression or needle thoracostomy. I'm showing you this as a reference to you guys, but I would highly recommend that you enroll in programs like the ATLS, the Advanced Trauma Life Support course, because that will help you practice needle decompression. I've gone through it. It's very helpful. So there are two approaches to this. So ideally, you should use a 45 millimeter catheter or a gauge 14 to 16 angio catheter. Studies have shown that a regular IV catheter is not long enough to reach the pleura and actually do something for tension pneumothorax. So ideally, you should have these lengths, at least like 3 to 4 inches. The needle should be long, ideally with a catheter, okay? So there are two approaches. You could see here in the picture, there's your mid-clavicular approach and there's your anterior axillary approach. Now, classically, we prefer the mid-clavicular approach because it's easy to spot, to do, but more recently, studies have shown that the anterior axillary approach is also very useful and sometimes more successful than the mid-clavicular line, if you're technically proficient enough. So if it's the first time, not really sure what you're doing, and you find the mid-clavicular approach better to do, I would recommend that you do that instead. So how do you do the mid-clavicular approach? So try to find the sternal notch here. That will usually the bump here, and you go to the affected side. So that indicates you're in the second intercostal space. And then you get your needle, and then perpendicularly, you insert the needle like straight down. You don't do it at an angle. You push it straight down. Okay, that's your mid-clavicular approach. For the anterior axillary approach, you go to the 4th or 5th ICS. So from your sternal notch, you count. So from the 2nd, 3rd, 4th, 5th, and then the anterior axillary line. So the anterior axillary line, you insert there. That's also the approach for your straight up chest tube thoracotomy. Also very useful too. So when you insert the catheter, it should be perpendicular to the skin and should be above the rib. Never insert a needle below the rib because this is where your blood vessels and your nerves are. You're going to damage a lot of stuff. So above the needle, straight down, until you feel a pop or you hear a rush of air. That means you're in the pleura. You stop advancing the needle, then you advance the catheter because you don't want to damage any more organs with the needle, okay? So remove the needle and leave the catheter in place, securing it to prevent dislodgement. Another trick that other ER doctors do is they attach a syringe to the catheter filled with either like push down or filled with water. So when there's that rush of air that comes out of the tension pneumothorax, you could see it in the syringe. Sometimes you can't hear it because it's so loud in the ER. Okay? And reevaluate the patient if there's a positive clinical effect. Now, what are the pros and cons of a needle decompression? Especially with the mid-clavicular approach, it's pretty near the cardiac box right here, if you could see my mouse. So you can lacerate vessels, get the heart if you're not careful. That's a risk. But if you have a high suspicion of tension pneumothorax, there's more benefit that you do it anyway rather than not doing it. You know what I mean? The anterior axillary approach also you can damage, for example, here, like the liver on the right side, the spleen on the left side, because of the height of the intercostal space. And it's harder to do if you've never done it before, if you've never done a tube thoracostomy before. So the older traditional people like the mid-clavicular approach. Newer studies show the anterior axillary line is actually more successful because it's thinner. The chest here is thinner, so more success for the needle coming through and the pleura being breached. Okay, so there. Again, I highly recommend that you enroll in ATLS so you can have a feel of how to do this. Okay. All right. So once the patient is resuscitated and stabilized, tube thoracostomy may be performed later. For example, in other ER doctors, they say, for example, the mid-clavicular approach didn't work. They will try a second time using the anterior axillary approach. One or the other. Okay. All right. So here in America and other countries, there are actual specific kits for needle decompression. So you see here, the needle is long, like an angiocath, and it's large with a catheter. Okay. So that's the ideal setup, ideally, that you have a specific needle decompression catheter. But if not, again, use a 45 millimeter length catheter at least with the needle. It should be that long, or 14 gauge to 16 gauge angio catheter, ideally. All right. So next to the next T, so we're done with tension pneumothorax. Next, cardiac tamponade. So what is cardiac tamponade? So it results from pericardial fluid accumulating under pressure. So if you see this picture here, usually there's a very thin layer of fluid in the pericardial sac, but sometimes when there is more fluid, like because of chest trauma or cancer that's secreting pericardial fluid, it exerts pressure on the heart and it will cause it to have arrhythmias, hypotension, and then cardiac collapse. Okay. So again, you have to keep in mind what are the associated conditions that can make you suspect to have cardiac tamponade. So again, if you remember from the table from the first few slides, it's the patient has post-cardiac surgery, chest trauma, cancer, especially in the chest, or known to have pericardial effusion. That's very helpful. No, it's useful if the patient arrested in hospital because you have all the history, but if not, you need to have a high level of suspicion. So what are the symptoms? If you're able to get the symptoms from the family or friends, usually the patient will complain of acute chest pain, difficulty of breathing, fast heartbeat, tachypnea, and fast breathing. Okay, but that's not very specific. That's not very helpful. So what are the signs? So the signs, not very specific: tachycardia and hypotension. Now, if you're lucky enough to examine this patient before he arrested, a very classic triad for cardiac tamponade is the Beck triad. So what is this? So hypotension or low arterial blood pressure, dilated neck veins, so distended neck veins, and when you try to auscultate while the heart is still beating, there are muffled heart sounds. Now, ideally, to diagnose cardiac tamponade, you should have an X-ray, echocardiogram, but during an arrest, that's difficult to do. However, the AHA did say point of care cardiac ultrasound during an arrest can help, definitely help in identifying cardiac tamponades during a cardiac arrest. Not all hospitals, I understand, have POCUS. That's point of care ultrasound. But in the hospitals that do, St. Luke's, Makati Med, it's a very helpful tool. Okay. And it will also help you in pericardiocentesis. That is the management of a cardiac tamponade. So if a patient comes in, very strong history of cardiac tamponade, you think this patient has it, what can you do about it? So our goal is to get rid of the extra fluid in the pericardial sac. So how do we do that? So the management for or urgent drainage of a cardiac tamponade is percutaneous pericardiocentesis. So there are 3 different approaches. You can see it here in this picture. And I'll talk about them one by one. Okay. So there's first the apical approach. So the needle is inserted 1 to 2 centimeters lateral to the apex beat, around the 5th to the 7th intercostal space. You're supposed to advance the needle over the ribs to avoid the intercostal nerves or vessels, but it's very near to the heart and other vital organs. So ideally, this should be done with point of care ultrasound. Another one is the parasternal approach, the one here, very near the heart. A lot of things can go wrong. The needle insertion site is in the 5th left intercostal space, close to the sternal margin, so near here, near the sternal margin. So if you're going to insert the pericardiocentesis needle, it's perpendicular, like straight down into the space until you can aspirate blood or fluid. Okay. So what we prefer in the emergency room, traditionally, this is the subxiphoid or subcostal approach here, because you don't need imaging traditionally for this approach. It's the safest route without image guidance, least complications for pneumothorax. However, there are still complications like risk of right atrial puncture if you're not careful. Okay, so how do we do this? So in the ER, I've done this before on an arrested patient. Ideally, you should get a gauge 18 to 22 needle and syringe. And then you approach this below the subxiphoid process or the subcostal process. So the insertion site is below the left postal margin. You can see it here. You lower the needle to a 15 to 30 degree angle and you aim towards the left shoulder. Aim towards the left shoulder, okay? Aspirating all the while. So how do you know if you've hit the pericardial sac? Once you've aspirated non-clotting blood. So when you aspirate a cardiac tamponade, you don't expect to aspirate a lot of blood. Usually just a few mLs, no? However, if you start to have blood that starts to clot and it's a lot, you've already hit the heart. You need to back away. So it's very difficult. Percutaneous pericardiocentesis is an urgent procedure. It's difficult to do. There's a lot of complications. That's why the AHA does recommend that echo-guided pericardiocentesis has a greater success rate and minor complication rate. But traditionally, prior to point-of-care ultrasounds, what the cowboy people have done is they attach an ECG chest lead to the needle. And if you see an ST elevation in the ECG machine, that means you've hit the ventricular wall and you need to back off. So that was what was done before. So you can consider this. But yeah, it's not easy to do. But it can be life-saving if it's done well. Okay. So we're done with cardiac tamponade. Thankfully, it's rare. So that's good. Next, the next T is thrombosis. Pulmonary thrombosis, or basically a blood clot in the lung. So you see in this image here, the lung has a blood clot, so it causes parts of the lung to not receive perfusion, and the patient goes into arrest because hypoxia, difficulty of breathing, heart does not get enough oxygen, cardiac arrest. So what are the symptoms of pulmonary embolism or pulmonary thrombosis? It's a constellation of symptoms ranging a lot, but the most common number one is dyspnea, 73%, pleuritic chest pain or sharp chest pain, 66%, cough even, it's 37%. Now, acute onset or sudden onset dyspnea is more common, around 40%, compared to gradual onset dyspnea, around 20%. So what are the signs? Signs is patient presents with tachypnea 70% of the time, with crackles or rales 50%, and usually concomitantly half the time, or 44%, the patient will also have a DVT in one of the legs. Okay, that's important to find out. Also, they might present with tachycardia or arrhythmias, like 30%, like new onset atrial fibrillation. That could give you a clue. Okay. However, if the patient comes in arrested already and you can only have the history to go by, these symptoms and signs can give you a clue. Also, with the associated conditions, like the patient has been immobilized for a long time, had recent surgery, especially long bones. They also have cancer. That's also a risk factor. So we'll talk about that in the next few slides. Oh, hold on. There. So the type of pulmonary embolism focused in the American Heart Association ACLS guidelines is fulminant pulmonary embolism, because there are many kinds. There's minor, there's major, there's fulminant. Fulminant pulmonary embolism is a large embolism that can cause catastrophic effects, cardiac arrest. So most of the management and diagnosis here is for fulminant PE. So please keep that in mind, because ideally pulmonary embolism should be a whole other lecture, because it's difficult to diagnose. There's so many ways how to diagnose pulmonary embolism, but we'll just focus on the ones that cause cardiac arrest for now. Okay. So usually the presenting rhythm during a cardiac arrest, cause of pulmonary embolism, 50% of the time is pulseless electrical activity. So if you remember from your ACLS lessons, pulseless electrical activity is any organized rhythm that you see on the cardiac monitor, but there's no pulse. Okay. Actually, a lot of the 5H's and 5T's, they're associated with a PEA. So when you see that, you should really look for your 5H's and 5T's for a reversible cause, because shockable rhythms overwhelmingly, like 90%, is due to cardiac thrombosis. The rest, you should consider other causes. Okay. Now, how do you diagnose a pulmonary embolism? How do you know? So ideally, since it's so difficult to diagnose and it's a complex condition, you should have a multidisciplinary approach with a team of experts. a pulmonologist, cardiologist, internist. In other hospitals, you have what you call a pulmonary embolism resuscitation team, PERTs, but not everyone has that. Okay, so what can give you a clue? So ideally, you should determine the pre-test probability of your patient having pulmonary embolism. So if you see a patient comes in with cardiac arrest or suspicious symptoms, you need to ask yourself, how likely is my patient having pulmonary embolism? So thankfully, we have a lot of validated scoring systems that can tell us, that can give us a clue. So there's the Wells score, the modified Wells score, or the modified Geneva score. What a lot of doctors like to use, because it's been the most extensively researched, is the Wells score. So here. So thank you, MD Calc, for this image. So let's go through Wells criteria for pulmonary embolism. So you can pull this up in your phone. You can look for the Wells criteria calculator. You can go through it just to see if the patient has a chance of having pulmonary embolism or not. So for example, does the patient have clinical signs and symptoms of DVT? Does he have leg swelling, tenderness? Is he known to have a history of PE? If yes, it's plus 3 points. If PE is the number one diagnosis or equally likely, like because of his history, yes is plus 3 points. If the heart rate is greater than 100 upon presentation or before cardiac arrest, yes, 1.5 points. Or if the patient has history of immobilization at least 3 days or surgery in the previous 4 weeks, it's another 1.5 points. If the patient has previous diagnosed PE or DVT, it's another 1.5 points. That will tell you that he might have another one again. If the patient had history of hemoptysis recently, it's plus 1. Also, if the patient is known to have cancer and was treated within 6 months or is in palliative care, yes, plus 1. You can consider Wells criteria. So what does that mean? Your patient will have a high probability if he has a score of more than 6. So that means more than a 37.5% prevalence of pulmonary embolism in people with a score of more than 6. If it's moderate, 16.2% prevalence. You can still consider, but if your patient is still alive and well, you will do more testing before you consider giving management. Low is less than 2, the score. So that is less than 1.3% prevalence. So having a Wells criteria or determining the pretest probability of pulmonary embolism is very important when you're trying to diagnose PE in these patients. Okay. So in patients who are unlikely to have pulmonary embolism, like they score low on the Wells criteria and they have a negative D dimer and they were discharged home, studies showed that the incidence of a missed pulmonary embolism on a 3-month follow-up is just 0.5%. So this is a very useful tool, even if you don't have to use it for cardiac arrest. Okay, but this is just a quick discussion of pulmonary embolism. So ideally, in an ideal world, if your patient is stable enough, you should be doing these imaging. This is the gold standard to diagnose pulmonary embolism, which is your CT pulmonary angiography or your VQ scanning, ventilation perfusion scanning, or your catheter-based pulmonary angiography. But the world is not ideal, and we need to deal with this during a cardiac arrest in the emergency room. So what do you do? So if a patient, for example, is very unstable or straight up in an arrest, you can do what you call a presumptive diagnosis. If the findings are present, you can start pulmonary embolism treatment already. You presume that the patient has a very high chance of PE, along with your Wells criteria. So for example, if this can be done, you can do a bedside lower extremity ultrasound. If DVT is present, start management. Or if you even have time to do transthoracic echocardiography during an arrest, I don't think this can be done, but it has been suggested in unstable patients. If you see a new right ventricular strain or direct visualization, literally you can see the thrombus in the heart, you start management. Okay. So what do you mean by how do you manage pulmonary embolism? So the AHA has guidelines for that even during arrest. So if you look here, this table here are the recommendations for pulmonary embolism. if you look at COR means criteria of recommendation. It shows how strong the recommendation is. So recommendations goes from 1, which is strong, 2A, which is moderate benefit, 2B is weak benefit, but still beneficial. 3 is harm. Okay, so these are all beneficial recommendations according to the HA. And the LOE means level of evidence. So how much evidence do these recommendations have? So LD means limited data. So that means it's not based on randomized controlled trials, it's on observational trials, but still useful. So what are the recommendations? Number 1, in patients with confirmed, known pulmonary embolism and they're in arrest, thrombolysis, surgical embolectomy, and mechanical embolectomy are reasonable emergency treatment options, whichever can come first, okay? Thrombolysis, usually RTPA, okay? Number 2, so this is a moderate benefit, okay? Number 2, this is a weak benefit. Thrombolysis may be considered when the cardiac arrest is only suspected to be caused by pulmonary embolism. So if it's only a suspicion, you can still consider giving thrombolysis in a patient. So how do we do that? So this is for your reference. I still suggest you look it up or ask your expert opinions about this. So again, PE is difficult to diagnose, especially in the intra-arrest setting. When a return of spontaneous circulation or ROSC is not obtained and PE is strongly suspected, the evidence supports you can consider thrombolysis. So in the USA, TPA, like alteplase especially, is used during an arrest. They prefer giving a 50 milligram IV bolus over 2 minutes and can be repeated after 15 minutes if the patient does not have ROSC. This is only during an arrest, because ideally our TPA for pulmonary embolism in a patient that's alive, it's over 2 hours. Infusion is over 2 hours. So the 50 milligram IV bolus is only during an extreme emergencies during an arrest. Okay, so this is something you can consider. So, but this, you can give alteplase or RTPA in patients with low risk of bleeding. They're not on anticoagulants. If your patient is known to be on warfarin already or other anticoagulants, it is recommended you start the patient on unfractionated heparin instead. As for what is the dose for unfractionated heparin in a cardiac arrest, that remains to be determined, but for alteplase, 50 milligrams IV. That's what's recommended, especially in UpToDate. That's where I got my information from. Okay, but there. So thrombolysis is still something you can consider in suspected PE. This is what the AHA recommends. It's still a benefit. What are the risks? Of course, you don't want your patient to bleed out or to subject them to very strong anticoagulant unnecessarily. This is why you need to have a strong suspicion for pulmonary embolism. So in a retrospective study of 23 patients with PEAs, and to confirm to have massive pulmonary embolism because of echocardiography, when they were given RTPA, they had ROSC within 2 to 15 minutes of administration of 50 milligrams of RTPA. So this is from the PEA-PETT study. It's a small study, but it does show a huge benefit for confirmed pulmonary embolism cardiac arrest patients that you give thrombolysis. Okay. So what's the next T? So it's cardiac thrombosis, everyone's favorite, the heart attack. So cardiac arrest with shockable rhythms like VFib or ventricular tachycardia have very high rates of severe coronary disease. So post-resuscitation ECGs, 96% have STEMI in one patient population, and 42% have NSTEMI. So when you see a patient with a presenting shockable rhythm, most likely it's cardiac in origin. So in patients who presented refractory out-of-hospital VFib or VT, 85% were found to have severe coronary artery disease. So, coronary artery disease is a very major killer in the world. So several studies show improved neurologically favorable survival when early PCI, early angiogram is performed right after cardiac arrest of a patient with STEMI. And because of this, you see in the recommendations for PCR, percutaneous cardiac intervention after cardiac arrest, we have the strongest recommendation, number one, or one. And BNR means the level of evidence is B, so that means it's a non-randomized studies were used. So the AHA strongly recommends coronary angiography should be performed emergently for all cardiac arrest patients with suspected cardiac cause of arrest. And you see there's evidence of STEMI on the ECG post-cardiac arrest. Send them up to the cath lab. Even if they're comatose, that's fine. Send them up to the cath lab because studies show survival rates and also neurological survival rates. They're not vegetables if you're able to get them up to the cath lab in time. So if you see here, the last one here says, independent of a patient's mental status, coronary angiography is reasonable in all post-cardiac arrest patients for whom coronary angiography is otherwise indicated. This is a 2A. So that's the second highest recommendation. That's a moderate benefit, okay, with limited data. So how about for people that don't have a STEMI? Can we still do PCI after cardiac arrest? Yes. So if you look here in the second row, it's a 2A recommendation, so moderate benefit. So emergent coronary angiography is reasonable for select patients who are comatose after out-of-hospital cardiac arrest of suspected cardiac origin, but you don't have a STEMI on ECG. If it's suspected and STEMI, yeah, that could still be of benefit, but it doesn't have a much of a benefit as those with STEMI. But you take what you get. No? So I would recommend, if you strongly suspect a patient with STEMI and your hospital is capable of doing PCI, once they get stabilized, once they have ROS, send them up to the cath lab. Okay, call your cardio. So there. So that's the recommendations for the AHA for thrombosis of cardiac origins. Very clear. Okay. Okay, toxins. So toxins, it's a very large topic to discuss because there's so many toxins that humans can be poisoned by. So this is not an exhaustive list. These are the ones that you see here in this slide is only by special mention in the AHA. Okay, so there's opioid overdoses, benzodiazepine overdose, beta blocker overdoses, carbon monoxide exposure. But it's very important that you have a background of toxins and toxicologies. It's a very interesting field. So if you suspect patient being poisoned by one thing, find the antidote. That's basically it. Give the patient the antidote of a suspected overdose. That's it. That's the basic takeaway here. But we'll just look at the special mentions of AHA for the 2020 guidelines for certain toxins. So number one, for opioid overdose, because as we all know, there's an opioid epidemic in America. This is why it's such an important mention in the AHA guidelines. So what are these recommendations for an acute opioid overdose? So patients who overdose on morphine, fentanyl, they come in arrested, pinpoint pupils. They're known to be abusers. So number one, so you notice all these CORs or criteria recommendation, all number one, very strong benefit recommendations. It says for patients in respiratory arrest, just do your basic BLS, bag valve, mask ventilation until spontaneous breathing returns, and do ACLS if the patient's in arrest. Simple. This is for all toxin cases, like even for all patients who come in with a cardiac arrest and you suspect they are poisoned, you still go through your BLS, you still go through your ACLS. Same thing. So another recommendation for opioid overdose for the AHA is for patients known or suspected to be in cardiac arrest and naloxone is not working. That's the antidote for opioids, by the way. You should still focus on high quality CPR. Same banana. So naloxone is the antidote for opioid overdose, but this is only really recommended in patients who are opioid naive. They're not like chronic abusers of opioids, so that's hard to know, right? But just for reference's sake, we give 0.04 milligrams of naloxone IV or IM. Some EMTs in the US have a nasal naloxone. So you repeat until the patient's spontaneous respirations return. Not until they're awake, no. It's only when respirations return. Even if they're comatose, it's fine. That's when you stop the naloxone. If you reach the max dose to 5 to 10 milligrams, you have to reconsider the diagnosis. Okay, so there. So here in the last one, lay and trained responders should not delay activating the emergency response teams or systems while waiting the patient's response to naloxone. So just call for help immediately, give the naloxone, do your BLS, do your ACLS. That's it. Okay. So we'll move on to the next toxin that's important to the HA. That's benzodiazepine. So very common in the Philippines, also actually Xanax. What else? Valium. No? So it says here, first time we've seen a 3 here in the criteria recommendation, it's harm. So they do not recommend the antidote for benzodiazepines, which is flumazenil, in patients with undifferentiated coma. Okay, it confers risk and it's not recommended. You only give the antidote if you have a high suspicion this patient has a benzodiazepine overdose. Okay, because some EMTs, they just give what you call a coma cocktail. They give a naloxone, flumazenil, glucose, whatever, just to see if the patient will respond. But the AHA is like, no, flumazenil, if you give it to a patient that doesn't have benzodiazepine overdose, actually causes harm. So it says here, an alternative to flumazenil is just bag valve mask ventilation. Your basic BLS and your ACLS, just do that. That's fine. Okay. So if you suspect the patient having a benzodiazepine overdose, it's usually non-specific signs and symptoms. It's respiratory arrest, hypotension, drowsiness, and there's a known history of intake of benzodiazepines. You may give flumazenil. Patients without benzodiazepine tolerance and no history of seizure disorder, you may give an initial dose of 0.2 milligrams IV slow push of flumazenil. Okay, a response is expected in 2 to 5 minutes. Okay, you may give up to a maximum dose of 1 milligram. Okay, again, respiratory. So there. So it's important that you have a high suspicion and you know what you're looking for if you suspect the patient's having toxins as a cause of the arrest. Okay. Another important toxin to the AHA is beta blocker overdose and calcium channel blocker overdose. So, in the Philippines, especially for senior and middle-aged patients, they do take a lot of beta blockers or calcium channel blockers like metoprolol, verapamil, and more often than not, a lot of these seniors are confused and they take more than the recommended dose because they repeat the doses. They get confused throughout the day and they take more than what they should. And the side effect of that is cardiac arrhythmias and cardiac arrest. So if you look at both beta adrenergic blocker overdose and calcium channel blocker overdose, actually the treatment is the same. So if you look at beta blockers here, for the 2A recommendations, the antidote is high-dose insulin and glucose. If you suspect patient overdosing or having a severe adverse reaction to beta blockers. So how do we give that? According to literature, typical insulin dose in these studies is 1 unit per kilogram bolus, followed by an infusion of 1 unit per kilogram per hour, titrated to clinical effect. Plus, you give at the same time dextrose, so the patient has a hypogly, 25 to 50 grams IV. And then you repeat if the patient still has hypoglycemia. So you have to do repeat CBG testing while you're giving insulin. Okay. Also, studies show for beta blockers, glucagon can help reverse the effects of beta blocker overdose. Usually give 1 to 5 milligrams of glucagon IV, and then may repeat up to 50 milligrams maximum for glucagon. Also, it's the same for calcium channel blockers. You can give high-dose insulin and glucose, but you can also give calcium. So we prefer giving calcium gluconate 30 to 60 ml, 10% solution bolus, then 0.5 max calcium kilogram per hour once the patient has been stabilized. You can also give glucagon for patients with channel blocker overdose as well. Same thing. A last one, 2B recommendation, which is weak. It says here, for patients with both beta blocker and calcium channel blocker overdose who are in shock or cardiac arrest despite pharmacological therapy, you may consider ECMO. But not all hospitals have ECMO, much less emergent cardiac arrest ECMO. So that's something that we have yet to achieve in our country, but that's something you can consider. Okay. All right. So another one besides beta blockers is sodium channel blockers, including tricyclic antidepressants. So in the Philippines, a very common sodium channel blocker we give to patients is amiodarone. So that's something you need to consider. So patients with a severe adverse effect to amiodarone or they overdose on amiodarone can have severe arrhythmias and cardiac arrest. So what is the recommendation? So according to the AHA, administration of sodium bicarbonate for cardiac arrest of life-threatening cardiac conduction delays due to a sodium channel blocker, for example, prolonged QRS, can be beneficial. So what do we recommend for sodium channel blocking? 1 to 2 mEqs per kilogram or 1 to 2 ml kilogram of 8.4% sodium bicarbonate, repeated as needed to achieve clinical stability. But yeah, we usually give it depends on the kilogram of your patient. You can give sodium bicarbonate for patients you are suspecting of sodium channel blocker overdose. So 1 to 2 mEq per kilogram. But again, please look up and look it up in your drug formularies and also consult your experts to be sure. So here again, for example, sodium bicarbonate is not helping. You can consider ECMO, but that's difficult to do. Okay. Tricyclic antidepressant is not as common in the Philippines. That's your amitriptyline. So there's not much antidote for amitriptyline. I'm not very sure, but for for the AHA, they do say ECMO can be given for TCA toxicity. So I do recommend that you read up on the antidotes for TCA toxicity, but it's not that common in the Philippines. I'm not very familiar with it either. All right, another last one for what's important for toxins, HA-wise, we can talk about carbon monoxide poisoning, digoxin, and cyanide, but I'll focus mostly on cyanide and digoxin. So digoxin is a heart drug that a lot of patients use, and sometimes when they overdose or they have an adverse effect or they have toxicity, they do have arrhythmias and they do have arrest. So according to the AHA, the antidote for digoxin toxicity, if it's available, is anti-digoxin FAB antibodies. Should be administered to patients with severe cardiac glycoside toxicity. So there are dosing regimens for your anti-digoxin FAB antibodies, but for example, your patient's already in cardiac arrest and you have no idea how many milligrams of digoxin your patient has ingested. Empiric dosing is usually 10 vials of digoxin FAB antibodies or 5 vials in children, and you give it with slow IV push. So this is for patients in arrest and you have no idea what the dose of digoxin your patient has. But for more particular dosing regimens for your antibody for digoxin, I would recommend that you look it up, especially in UpToDate. It's very useful. Okay. Now, for carbon monoxide, usually these are patients that are exposed, especially car fumes, industrial fumes, or like in places that are dangerous, like caves, volcanoes. It's an odorless gas, and they can cause lethargy, difficulty of breathing, respiratory arrest, cardiac arrest. So usually when you receive these patients, there's not much of an antidote for them. You still do your ACS-BLS procedures, but the AHA does say hyperbaric oxygen therapy may be helpful in the treatment of acute carbon monoxide poisoning patients with severe toxicity. So this means that your patient should not be in arrest when you put them in the hyperbaric oxygen chamber. So once the patient has been resuscitated, you can consider and stabilized enough, you can consider putting him in a hyperbaric oxygen chamber as an antidote to carbon monoxide poisoning. Last one, cyanide poisoning, which is very interesting. Actually, in the Philippines, it's pretty common before, especially in children, cyanide poisoning, because it was a lot in jewelry cleaners or silver cleaners before. This was like back in the 90s, but now a lot of the jewel or silver polish has been changed to not include cyanide. Before it was quite prevalent, cyanide poisoning. So usually these children or adults will suddenly have respiratory arrest, cardiac arrest after the ingestion. Usually it's ingestion. Kids just drink jewelry polish. I have no idea why, or they're poisoned by other people. There was a famous case in Thailand about that. So when they're suspected of poisoning, the antidote for that is hydroxycobalamin, and 100% oxygen can be beneficial for cyanide poisoning. So how do we give hydroxycobalamin? So usually we give 70 milligrams per kilogram IV. The typical adult dose is 5 grams. So it's usually effective for most adults, 5 grams for cyanide toxicity, usually through inhalation. Like I said, cyanide also is present in smoke inhalation victims. So that's something you can consider too. Okay. So this is by no means an exhaustive discussion of toxins, but I do recommend that you look up toxidromes and treatment and antidotes. It's also important because, toxicity is quite prevalent in the emergency room. Also, really important for toxins is number one thing, also while you're doing ACLS and BLS on a patient, is decontamination. What does that mean? If your patient has traces of the poison on their clothes, you need to strip them of their clothes. You need to wash them down because that does help them also reduce contact with the poison. That also helps too. Okay. Thank you. So I hope this is helpful. I know it's a lot to take in, but you can ask me any questions. And I do recommend that you look up, especially on the topics of interest that you have. So here are my references. A lot is from Up to Date, a lot is from the AHA and from certain studies. So thank you again. So I'll stop sharing. Okay. So does anyone have any questions or concerns or anything about what we talked about, the 5 T's today? So you can just put it in the chat box, and I'll just wait for our lovely admin to facilitate. Thank you.
Hello, Doc.
Hi, hello, yes,
We have question here po,
sure.
prepared. Ito po. First po, in the dizzy patient, what are the red flags of... wait po. I'm so sorry, wait po. Um, um, wait po, Doc.
Not a
Sorry.
problem. I do recommend everyone that you go to the AHA website and look up the 2020 Advanced Cardiac Life Support Guidelines. Everything is there. All the algorithms, all the discussions is there. It's quite long, but then it's very fruitful if you want to master cardiac arrest. Everything is there. It's supposed to be updated every 4 to 5 years, so the newest guidelines should come in this or next year.
Doc, here na
Yes.
po.
Mm.
First, is it feasible to insert a CTT during cardiac arrest?
Yeah, actually, you know what? If you're really gung ho and you could do it within like really quickly, some physicians just straight up want to do a CTT instead of needle thoracostomy. However, remember there's quite preparation. You need to have your CTT set with you when you decide to do a chest tube. That takes time. And remember, time is of the essence here. If you can do it within, like, if it's already prepared, you're able to do it in time, you're confident, you could do it fast, sure, why not? I mean, it's less of a step anyway. But if you think your patient's already crashing, it's already crashed, and you already have your catheter in hand, you can do needle thoracostomy, then convert to a CTT. It really depends on the time that you have.
Alright po. Here pa po,
Hmm.
in your experience po, what symptom or sign, uh, wait a minute po.
Sure.
Eto po. Is it okay to do pericardiocentesis during cardiac arrest?
Yes, you can. I've done it before, but you need to have a really high suspicion of cardiac tamponade to do that. Ideally, you should be doing it with experts as well. Um, if if you have POCUS, your point of care ultrasound, that could definitely help you do pericardiocentesis. It's a technically difficult thing to do, so you need to have a high suspicion because you can lacerate a lot of organs if you just do it during an arrest and you don't really have a strong clinical suspicion. Okay. So, but if you have a strong clinical suspicion, that could really benefit the patient. So, if you don't have imaging, you can try the subcostal or subxiphoid approach. I suggest you study that because you don't need imaging. But however, there are pros and cons to that too.
Alright po, thanks for answering po, Doc. Next question po. Is it safe to give thrombolytics during CPR?
Well, the AHA has this debated about that. They said that, for confirmed pulmonary embolism patients and you give thrombolytics during a cardiac arrest, there is a benefit, definitely. That's why if you see in their guidelines, it's beneficial. It is in their official recommendations. Now for suspected uh pulmonary embolism patients and you give during a cardiac arrest, there still seems to be a benefit because the benefit of thrombolysis is greater than the risk of thrombolysis is less than the benefit of giving thrombolysis if you have a high clinical suspicion of pulmonary embolism. That's like don't give thrombolytics if you don't have a high suspicion of pulmonary embolism. That's why I gave you the Wells criteria. You need to talk to experts. You need to look at the clinical picture of your patient. When you say safe, that's relative because do you want this patient to have a return of spontaneous circulation? Yes, then the benefit is greater than the risk. But if not, there's risk of, bleeding out, stuff like that. It's always the risk to benefit ratio, especially in a cardiac arrest. That's already the endpoint. Yep.
Alright po. We have question po here sa comment section.
Mm,
What
mm.
is the cure for tolerance toxicity from shoe glue intoxication po?
Wow, toluene toxicity. This is like I said, this is by no means an exhaustive course, especially for antidotes and toxicity. Okay, when in doubt, everyone in this Zoom meeting, I want you to listen very carefully. When in doubt and you need help, you must call the PGH Poison Control. They will give you all the antidotes and the steps you need for toluene toxicity. God, toluene toxicity. Oh, I'll have to look that up. There are very good toxicity tox guidelines, but if you don't have them on hand, call the PGH Poison Control. They're open 24 hours. The tox fellows will help you. I was a tox fellow before, but I totally forgot about toluene toxicity. But call PGH. They will help you. Call PGH Poison Control. Okay? When in doubt, call. For any toxicity, they're definitely going to help you. Toluene toxicity, I haven't really encountered that much during my tox rotations. More of kerosene, to be honest. There's but I'll get back to you about that. That's really interesting. That's a good point. But yeah, call PGH.
Alright do. Ito po for our last question.
Mm.
Do you recommend giving dextrose, thiamine, naloxone, and flumazenil for all suspected drug overdose in arrest?
What did I say about what did the AHA say about that? Did we not talk about this a couple of slides ago? What did we say? This is the only one with harm. Look at this. So I hope this answers your question. Oh wait, let me share my screen again. Wait, hold on. So if you look at my lecture before, the AHA says no, you cannot give flumazenil to just anyone with a suspected drug toxicity, but you cannot pinpoint benzodiazepine. No, cannot, because it's more harm than good. It's a level 3. It's a level 3 recommendation, which means harm. So if you're not sure what caused the toxicity of your patient, just go through ACLS BLS. That's fine, because the HA says if you can't give flumazenil, that's okay. just go through with your resuscitation. It's equally as effective. Do not give flumazenil willy-nilly. Okay? No. You know, like I said, that's what you call that's the coma cocktail. We don't do that anymore. Unless you have no other choice and you're willing to risk your patient. So that's my thought about that.
Alright po. Do we have any question po from
Wait,
the
let me look up
audience?
toluene toxicity because I'm
Alright po.
annoyed. Hold on. I
Wait
have my
lang.
tox. So if you go to toxbase.org, it's very useful, but it's per pay. So International SOS. Hold on. Fortunately, my company has this. Wait, hold on. Give me a minute. But when in doubt, just call PGH. I can't go into my talk space, sorry, for toluene toxicity, but call PGH. They will answer all your questions and also the step-by-step what to do. And they also follow up, which is great. Okay, I hope that helps you.
Alright, Doc. I think there are no more questions.
Okay, all right. Thank you very much, everyone, for your time. And I hope you've learned a little bit of something today. I highly recommend that you read up on your AHA 2020 guidelines. It's for free online. It's a couple of pages, but it's going to help you with your practice for sure.
Alright, Doc. Thank you so much.
Thank
so
you.
much
Thank you,
po.
everyone. Bye-bye.
Bye-bye. You can leave the Zoom meeting na po. Thanks.
Bye.
Yung patient yung meron ng pneumonia, ganito yung itsura ng intubation nyo. Kaya pwede natin bigyan. Viral filter. Kasi meron siyang droplets. Kayong lahat i-pull out. Yay! So, additional value. And then, yung entitled natin na